Hello, and welcome everyone to today's webinar in the Public Health Webinar Series of Blood Disorders. This webinar is presented by the Division of Blood Disorders at the Centers for Disease Control and Prevention, also known as the CDC. I'm Dr. Janet Kwiatkowski. I direct the Thalassaemia program at the Children's Hospital of Philadelphia, and I'm also a professor of pediatrics at the University of Pennsylvania Perelman School of Medicine. I'm delighted to be with you to moderate today's webinar. Our topic is Overview of Novel Thalassaemia Treatments. Before I introduce our guest speaker, I'd like to go over a few points and helpful tips for joining this webinar. Upon joining the webinar, you will see two audio options. You can opt to listen via the speakers on your laptop or by using the phone to call in. If the phone option is chosen, the webinar toolbar will provide you with a phone and access number and audio PIN. All audio will be muted. At the end of the presentation, there will be time for questions. To submit a written question, please use the questions area of your toolbar. The presenters will respond to as many questions as time allows. Today's webinar will last approximately 1 hour, and please note that this webinar will be recorded. We will begin today's webinar first with two brief audience polls. First, we are interested in knowing more about you. Please select your response to the poll question now. Which of the following statements best describes you? Select one of the following: a healthcare provider such as a physician, nurse, PA, NP, or pharmacist, a public health professional such as an epidemiologist, social worker, health educator, a person with thalassemia or a family member, a community-based organization, or an industry partner. Okay, so it looks like we have a bit of a mix, primarily healthcare providers, but a number of patients and family members, industry partners, and public health professionals as well. We'll now move to the second poll. And this is, what region of the world are you from? Please select one of the following: North America, South America, Europe, Asia, Africa, Australia, New Zealand. We'll just give you a minute to answer. Okay, so it looks like the vast majority of people are from North America, but we do have people joining from Europe, Asia, as well as Africa, Australia, and New Zealand. So welcome to everybody. I know some of you, it's quite late right now, so thank you for joining. Great. Now it is really my great pleasure to introduce today's presenter, Dr. Sujit Sheth. Dr. Sheth is the Chief of the Division of Pediatric Hematology and Oncology, as well as the Vice Chair of the Department of Pediatrics at Weill Cornell Medical College. He's also the Director of the New York Comprehensive Thalassaemia Program. I've had the privilege of collaborating with Dr. Sheth over the past several years on a number of research as well as health service projects aimed at improving comprehensive care for patients with thalassemia. Dr. Sheth has published extensively and given numerous lectures on the topics of thalassemia and iron overload. His knowledge of thalassemia is really quite vast, and he's always available to answer questions or share his opinions on topics. He's really been a trusted colleague and a friend, and it's really my great honor to introduce him. So Dr. Sheth, welcome, and let's begin.
Thank you so much, Dr. Kwiatkowski. It really is my pleasure to present today. And what I'm going to do is really present an overview of the novel therapies that are either already approved or in development and should be approved in the near future. This is going to be a sort of 30,000-foot view of things, and I'm not going into exquisite detail, but if there are questions that are specific to those details, then I'm happy to answer them, of course. These are my disclosures. I will be talking about some therapeutic strategies that are in clinical trials currently and not approved by the FDA. So this map really shows the distribution of thalassemia worldwide, and you can see that most individuals who are affected are in Asia and parts of Africa. There's about 80 to 90 million carriers worldwide, and about 60,000 individuals are born annually with thalassemia. It's estimated that in the US, there are about 2,000 individuals who are affected with a thalassemia syndrome, about 6,000 in Italy, and the prevalence is quite high in Asia, particularly South and Southeast Asia, as well as China. And the distribution worldwide is changing quite dramatically as a result of immigration and the different immigration patterns in terms of where patients from these countries are going. There is a wide spectrum of severity of thalassemia, ranging from mild, which is usually individuals with a carrier state, to sort of a more moderate, non-transfusion dependent state, which includes some genetic conditions that are not quite as severe. These individuals don't require transfusions as a routine, and so we consider them NTD, or non-transfusion dependent. And then you have the transfusion dependent individuals who usually start transfusions pretty early in life and require lifelong transfusions, and these are the most severely affected individuals with thalassemia. Now, this is a cartoon of normal erythropoiesis. The development of red blood cells starts with the hematopoietic stem cell and ends with a mature red blood cell being released from the bone marrow. There are two phases, really. The early stage erythropoiesis, which is really a phase of erythroid proliferation, which is promoted by erythropoietin, and late stage erythropoiesis, where there is erythroid differentiation and maturation, and this is regulated by members of the TGF-beta superfamily of ligands. Hemoglobin starts to be made somewhere in the middle at the stage of the basophilic erythroblast, and by the time the red cell is mature and comes out of the marrow, it is filled with hemoglobin and there is no nucleus left anymore. However, in thalassemia, and more so in beta thalassemia than in alpha thalassemia, there is ineffective erythropoiesis. And what this means is really that the early stage erythropoiesis is fairly normal. You have erythroid proliferation, which then over time becomes more and more pronounced. And there is some rapid accelerated differentiation, but then there is a maturational arrest. And these precursors that are arrested in the sort of polychromatic erythroblast stage then undergo apoptosis, and you don't have the red cell coming out of the bone marrow. And in this situation, there is accumulation of those TGF-beta subfamily, superfamily of ligands that is relevant as we move forward, and we'll talk about some of the targeted therapies to that. So as a result of ineffective erythropoiesis, there is impaired maturation of erythroid precursors, and this results primarily because there's an imbalance between the alpha and beta globin chain production because of the mutation. The formation of toxic hemichromes because of precipitation of the unpaired globin gene, whether it's alpha or beta, that results in apoptosis of the precursors, reduced RBC survival, anemia. That results in a sort of feedback where there's increased erythropoietin secreted from the kidneys, resulting in further proliferation, as well as activation of hematopoietic stem cells that are present elsewhere, resulting in extramedullary hematopoiesis, as well as, because there's an inappropriately low level of hepcidin, increased absorption of iron from the gut and iron overload as a result. This is a complicated slide. I'm not going to go through it in great detail, but suffice to say that there is ineffective erythropoiesis, which results in anemia. This anemia may or may not necessitate red cell transfusions. Because of the ineffective erythropoiesis and the red cell transfusions, there's iron overload, which has a myriad of complications, mainly endocrinopathies, heart disease, and liver disease. The extramedullary hematopoiesis results in hepatosplenomegaly and bone disease, and then the vascular disease that results mostly in patients who are not regularly transfused may result in a hypercoagulable state, which results in thrombosis, leg ulcers, cerebral infarcts, and the development of pulmonary hypertension. So a lot of different complications related to the basic problem, which is the relative excess of one chain or another, and ineffective erythropoiesis that results from that. The current management of beta thalassemia, I've broken down into TDT, or transfusion dependent patients as well as non-transfusion dependent patients. In the transfusion dependent patients, obviously regular blood transfusions, that results in iron overload much more quickly than in the non-transfusion dependent patients, and therefore iron chelation is necessary starting at a pretty early age, usually about a year to a year and a half into transfusions being started. You have to then monitor for complications, both complications of iron overload as well as complications related to the chelation therapy. You have to manage the complications should they occur. Obviously, the goal is to really prevent these complications from occurring, but should they actually occur, then you have to manage those. And then stem cell transplantation is a curative therapy, but so far we have really promoted it only in patients who have matched family donors, because the results from those kinds of transplants are actually pretty good, whereas the results from transplants from unrelated donors, even if they're fully matched, are not quite as good. The non-transfusion dependent patients may require periodic transfusions, usually at times of stress when their hemoglobin levels drop from either increased hemolysis or if there's an infection or at times of surgery. Iron chelation is required oftentimes for these patients. It may be intermittent and needs to be monitored for. Various other drugs that have the potential to increase fetal hemoglobin production have been tried with mixed success. Hydroxyurea, decitabine, and butyrate have all been used. And then these individuals also require monitoring for complications of disease, which include bone disease, especially, and vascular disease, as I mentioned, as well as for complications related to iron overload. And then stem cell transplantation is an option for these individuals as well. This slide just shows that the complications are quite different depending on whether you're transfusion dependent or non-transfusion dependent. In a well-transfused patient with transfusion dependent thalassemia, the complications are all, or potential complications are all going to be related to iron overload. So you can see on the left side of the slide, you can see that it's mostly endocrinopathies, cardiac disease, and hepatic disease. And then in the non-transfusion dependent patients, it's mostly related to vascular disease. So cerebral ischemia, pulmonary hypertension, and right heart failure, and then extramedullary hematopoiesis resulting in massive liver and spleen enlargement, as well as hematopoietic pseudotumors that may develop, particularly in the spine, and cause problems there, as well as venous thrombosis and leg ulcers, again, from the vascular disease that may occur. So the complications are quite different, and the monitoring and management is quite different. And this just gives you an overview of survival. And this is old data. It's from 2004, but it still does apply to this day because patients who were born later have better survival rates. As you can see from the Kaplan-Meier curve on the left side of the slide, if you were born in the 80s and 90s, you had a much better chance of survival compared to if you were born in the 60s. So without treatment, we know that somebody who has a beta-0 genotype, which means they produce no beta globin chains at all, if they were not transfused and not treated, they would probably die in the first 2 to 5 years. Whereas those with non-beta-0 genotypes may have variable clinical manifestations and may or may not require transfusion over time. We do know, I think it's fair to say that we have improving survival. And even though there is significant morbidity, the prevalence, the incidence of these morbidities is definitely declining. So tremendous advances have been made in the last several years. This includes an improvement in the safety of the blood supply, a decrease in transmission of infections like hepatitis and HIV, a reduced incidence of alloimmunization because of more extensive phenotyping and testing for and better cross-matching of blood. Oral chelation has been available, at least in the US, since 2005, and that has made a tremendous difference in the compliance of patients as well as the prevalence of iron overload in these individuals. We've had improved methods of monitoring iron overload, and this has enabled us to individually tailor the treatment regimen, including the chelation therapy. We've had improved treatments for hepatitis, which many of these individuals developed when they were hepatitis as well as HIV, which many of these individuals developed in the 80s. And then the outcomes of stem cell transplantation have improved tremendously as well. But despite all of these advances, there still remain some unmet needs. The curative options for patients without matched sibling or matched related donors are limited. We don't really have, or we didn't really have, a means of ameliorating ineffective erythropoiesis, which would reduce or eliminate transfusion requirement and in turn reduce iron loading. We were not really able to prevent iron. We are still not really able to prevent the iron overload from developing. We can treat it and manage it, but if it's developing, or if it's developed and you have complications, many of those complications tend to be irreversible. Reduction in bone disease is an unmet need, and overall improving quality of life, because this is a very cumbersome disease to manage. You have to go in for a transfusion every 2, 3, or 4 weeks. You have to take medications every day. You have to go to the hospital a lot for visits to endocrinologists, cardiologists, a lot of monitoring, a lot of scans and MRIs and echocardiograms and things like that. So there is a tremendous burden on these individuals. And so in order to try and meet some of those unmet needs, progress has been made to sort of approach therapies for thalassemia from different angles. So the basic pathophysiologic cascade, which is impaired alpha to beta globin ratio, you can try and change that by affecting the genes that are affected. So you can do that curatively by stem cell transplantation, or you can actually modify the gene expression by gene therapy or inducing fetal hemoglobin. You can also target the ineffective erythropoiesis, and that's been done using agents like JAK2 inhibitors, luspatercept, and the mini-hepcidins. And then in development, which we still don't have much data on, are things like the pyruvate kinase activators and the phosphodiesterase 9 inhibitors. So those are things that are in clinical trials that I won't be talking about today because we don't really have much data on them so far. So we'll start off with the first one, which is to try and influence ineffective erythropoiesis. So one of the things that we know is that during ineffective erythropoiesis, as the progenitor erythroid cells start the maturation process, they express increased amounts of JAK2. Now, in normal erythropoiesis, you have some expression, but because there's no impairment in maturation, that is not really that relevant. However, when there's ineffective erythropoiesis and an accumulation of these precursors, it may be relevant. And so one of the things that they thought of doing was to target JAK2, inhibit JAK2, and if you were able to inhibit JAK2, you might improve maturation that would then result in normal red blood cells being produced, or more normal red blood cells being produced. So there was the phase 2 trial that was done, which is called the TRUTH study. That did show that while patients with transfusion-dependent thalassemia showed a reduction in spleen volume, which meant that maybe there was some amelioration of extramedullary hematopoiesis and some enhancement of effective erythropoiesis, there was no significant reduction in the actual transfusion burden. So maybe these cells were not really coming out of the bone marrow any more effectively. And so that trial has been, so that drug has not, development for that drug has been halted, and that's not moving forward. What has moved forward is luspatercept. So this is a molecule that's complicated. So it's a recombinant fusion protein which contains a modified extracellular domain of the activin receptor 2B, which you see here up top in red. That's bound to the human IgG1 Fc domain, and that makes up the entire molecule. And what this molecule does is it binds to some of those members of the TGF-beta superfamily of ligands that I mentioned before, which are accumulating when you have ineffective erythropoiesis. And so if you remove that blockade, the thought was that you could actually allow maturation to proceed, and you would have more red cells being produced by the bone marrow. So the way that this would work would be to inhibit the SMAD2/3 signaling and promote erythroid maturation. So early data included animal studies as well as phase 1 studies in healthy human volunteers, and then the phase 2 trial, which included both transfusion-dependent and non-transfusion-dependent patients with beta thalassemia, which was published in Blood last year, showed that in the non-transfusion-dependent patients, there was improvement in hemoglobin levels, and in the transfusion-dependent patients, there was a reduction in transfusion burden. And so what they then did was, this just shows the sort of mechanism of action again. you have the normal erythropoiesis cartoon up top, and you have the same thing that I showed before, where you have ineffective erythropoiesis in beta thalassemia, erythroid proliferation, and accelerated differentiation but decreased maturation because of the TGF-beta ligands. And so if you can block those ligands, you might be able to allow maturation to proceed, and you might have better red cell production as a result of that. So given the early data from the phase 2 study in beta thalassemia, the BELIEVE trial, which was a phase 3 double-blinded placebo-controlled trial, was carried out. This enrolled about 330-something patients with beta thalassemia around the world, with a 2-to-1 randomization to luspatercept versus placebo. The primary endpoint was to see an erythroid response in week 13 to 24 compared to the 12 weeks prior to randomization. And the goal was to see if you could have a 1/3 or greater reduction in transfusion burden during that 13 to 24 week period, with the caveat that you needed to have at least 2 units less or 2 units fewer transfused during that period. Pre-specified secondary and additional endpoints included reduction of transfusion burden from baseline of greater than 33% or greater than 50% at different time periods, and a mean change in transfusion requirement from baseline, as well as some exploratory iron-related parameters. And these were the results, and these were published in the New England Journal earlier this year. The primary endpoint was met with about 21% of patients who are on luspatercept having a 33% or greater reduction in transfusion requirement compared with 4.5% in the placebo arm. And then the secondary endpoints were also all met with statistical significance. And you can see in the graphs here that there was either 33% or 50% reduction in transfusion requirement at the various time points that were considered. The additional endpoint where you were looking for a 33% or greater reduction in transfusion requirement during any 12-week period was also met with 70% of patients showing that response compared with 30% in the placebo arm. And if you went up to 50% reduction during any 12-week interval, that was 40% compared with 6.3% of individuals. So the primary and secondary endpoints were met, demonstrating a statistically significant reduction in transfusion requirement in those different periods. Also to keep in mind, luspatercept was generally quite well tolerated. The main side effects that were seen were arthralgia and bone pain. Venous thromboembolism was noted in a small proportion of patients, and we still don't have a completely clear idea as to what the specific risk factors for all of these individuals were, except to note that all of them did have increased risk factors for developing venous thromboembolism as well. And so as a result of that trial, Reblozyl, which is the trade name for luspatercept in the US, was approved in November of 2019. So in terms of looking at the potential effects of luspatercept, I think it's fair to say that we do have more effective erythropoiesis with greater output of red blood cells from the marrow of these individuals. There is reduction in extramedullary hematopoiesis, improvement in hemoglobin levels, reduction in transfusion requirement overall, which would then result in a reduction in iron loading, even though the endpoints, the exploratory endpoints that were considered in the BELIEVE trial related to iron overload were not statistically significant. The hope is that over time, as the number of units is going down, that the iron overload will be ameliorated significantly as well. Less bone disease, as well as a lower risk of iron overload related morbidities. So it really addresses, to some degree, virtually all of the unmet needs in beta thalassemia, except for the curative therapy unmet need, which I mentioned before as well. And so in order to try and address that, gene therapy has been developed, and gene therapy has been talked about and worked on in the laboratory for, I'm going to say, close to 40 years. And we've not really had major breakthroughs until this past decade. In the past, we've had the gene therapy would work in the mouse model fairly well, but wasn't really durable and did not really translate into humans that well. However, now we are in a new era, and gene therapy is definitely here as a very promising therapy in the future. So there are two approaches that have been used. One is addition of the globin gene, whether that is a functional beta globin gene, which is defective in beta thalassemia, or a functional gamma globin gene, which sort of bypasses the need for beta globin gene expression and allows you to make gamma globin and therefore have gamma globin bind to the alpha globin that's being produced to produce fetal hemoglobin. The other approach has been gene editing, which is twofold again. One is to reduce or to reverse the fetal hemoglobin repression that occurs because BCL11A is expressed. That shuts off gamma globin expression, and that is what results in the switch from producing gamma during the fetal period to producing beta in the postnatal period. And so if you could switch off BCL11A, then you might allow fetal hemoglobin expression to continue, and you might have fetal hemoglobin being produced instead of beta globin chains, and that could correct the anemia and correct many of the problems that these individuals have, reduce transfusion requirement and improve anemia. The other gene editing approach is to actually correct the beta globin mutation, something that's far more complicated, I think, to do, but something that is being worked on as well. So we'll talk about the gene therapy studies to date in the next few minutes. And the gene addition studies are really two that I'm going to talk about. One is lentiglobin BB305, which includes the North Star trials. The early studies are HGB 204 and 205, and then the more recent phase 3 studies include HGB 207 and 212. And then the other vector is the GLOBE lentiviral vector, which is developed in Italy. And I will talk about the phase 1/2 trial of the GLOBE lentiviral vector as well. I will also mention the gene editing trials and the data to date from both the phase 1/2 Thales study of ST400, as well as the phase 1/2 study of CRISPR-Cas9 gene editing using the CTX001 platform. And this is really hot off the press because this data was presented for the first time just last Friday at the European Hematology meetings in Frankfurt. So the basic premise of gene therapy is the same, whether you're doing gene addition or gene editing, and that is to essentially mimic an autologous stem cell transplant. So basically you are mobilizing stem cells from the bone marrow into the peripheral circulation using a drug called pyrixophore. Those are then collected via pheresis. Those CD34 positive stem cells are then taken to the manufacturing facility where they are transduced either with a vector which contains the beta globin gene, or they are edited using the CRISPR-Cas9 technology. And then these corrected stem cells are then tested and then frozen. In the meanwhile, the patient is prepared for the autologous transplant. There is conditioning, which includes myeloablation without immunosuppression, and depending on what protocol is being used, it's a single agent or two agent protocol. And then once conditioning is completed, the corrected stem cells are put back in, either through an IV infusion in the case of the BB305, or directly into the bone marrow, which is the approach that was used by the GLOBE vector in the GLOBE vector trial. So here are some of the results. So these are the results from the earlier trials, the HGB 204 and 205 trials of lentiglobin BB305. And you can see in HGB 204, 205 on the left side, you can see that this included 22 patients, 13 patients with non-beta 0 beta 0 genotypes, and 9 patients with beta 0 beta 0 genotypes. And you can see that 12 of the 13 patients with non-beta 0 beta 0 genotypes were actually able to to increase their hemoglobin levels to become transfusion independent, whereas 3 of the 9 beta 0 patients were able to achieve transfusion independence as well. So these are from the early studies, and if you look on the right-hand side panel, you can see that even in those patients that did not become transfusion independent, there was, for the majority of them, a significant reduction in transfusion requirement as well. So it seemed like you were able to either achieve transfusion independence or at least reduce the transfusion requirement quite significantly. Now, in order to optimize this, the company then instituted a refined manufacturing process and then carried out the subsequent trials, which are HGB-207 and 212. The refined manufacturing process was to try and improve the transduction of the number of cells that were transduced and to improve the vector copy number in each cell. And you can see the results here, and you can see that in the HGB-207 trial, which was in non-beta 0 patients, 18 of 20 patients were able to achieve transfusion independence. And in the HGB-212 trial, which is in the beta 0 patients, 11 of 12 patients were able to achieve transfusion independence. You'll also note that the hemoglobin levels that they achieved were actually better than the hemoglobin levels that were achieved in the previous trial here. So you did have improved transduction, you had better vector copy numbers in these patients, and therefore increased production of hemoglobin as well. The phase 1/2 trial of the intra-bone gene therapy using the globe vector, that included 9 patients, 3 adults and 6 children with beta 0 or severe beta plus mutations. Again, the vector used was the globe lentiviral vector. The approach was pretty much the same, with the significant differences being that the globe vector expresses the normal beta globin gene, and the vector itself is self-inactivating once the gene is introduced into the genome of the stem cell. Conditioning in the previous trial with BB305 was single agent busulfan. Here, conditioning was with thiotepa and triosulfan. And instead of introducing the corrected stem cells by IV infusion, they were introduced directly into the bone marrow. And the rationale there was to prevent the trapping of the infused stem cells in the reticuloendothelial system if they were given intravenously. So the thought was that you would achieve a greater delivery, a greater number of cells would be delivered directly to the bone marrow rather than having to go through the reticuloendothelial system where they could be trapped. So in terms of the results, three adult patients were treated first. None of them became transfusion independent, but they did have a reduction in transfusion requirement to 18%, 30%, and 67% of baseline. So at best, you reduced your transfusion requirement by 80%, and at worst, you reduced your transfusion requirement by 33%. In the 4 pediatric patients, the results were better. 3 patients did become transfusion independent with hemoglobin levels of 8.4, 10, and 14 at 12 months follow-up. And 1 patient who did not become transfusion independent actually had a reduction in transfusion requirement to about 82% of baseline. So not that much of a reduction, but maybe about 20% or so. In terms of safety, none of the gene therapy trials have had any deaths to date. Most of the toxicities were associated with the myeloablative conditioning regimen, including things like stomatitis, febrile neutropenia, thrombocytopenia, bleeding, elevated LFTs, etc. All things that you see in standard transplant. Even if it was from a matched sibling donor, you could see these same sorts of complications occur there. Veno-occlusive disease was seen in the initial cohort of patients on the BB305 trials, 204 and 205. All of them were treated successfully. Nobody had a lasting effect of that. And now all subjects are actually prophylaxed with defibrotide to try and prevent that from occurring. And there has been a reduction in incidence in the subsequent trials as well. So lots of different factors to consider when you are looking to see what affects the success of gene addition. The transduction efficiency, as I mentioned, in terms of how effectively you can get a vector into the stem cell, not one, but maybe even more than one vector into the red cell that integrates the beta globin gene into the genome of the stem cell. There was concern initially that this might increase the risk of insertional mutagenesis, but what they've shown is that the insertional sites are so varied, and there's probably over 20,000 insertional sites, so the risk of insertional mutagenesis is actually quite low. And the concern that we have is the concern that we had for that is not so great now. The transgene expression levels in terms of how well the transfected gene will actually express itself, that will determine how much beta globin is produced per copy of the gene in the cell. So maybe one copy is not going to be enough, and maybe you'll need more. So the initial studies with BB305 had vector copy numbers 0.6 to 0.7 per cell, and subsequent trials had somewhere between 2 and 3 copies per CD34 positive cell. And then, is there a difference in response based on whether you have a beta plus mutation or a beta 0 mutation? The quality of the stem cells, whether it's mobilized and collected peripherally or bone marrow, the pre-existing morbidities that a patient might have, adults might have more pre-existing morbidities compared to kids, and then the bone marrow microenvironment as well, myeloablative conditioning versus non-myeloablative conditioning. All of these are going to be looked at as we advance the field to see how we can optimize gene addition without causing significant complications. Gene editing strategies, the targets for gene editing include 1, disruption of BCL11A, as I mentioned, and 2 strategies are being used for that, either zinc finger nuclease or a CRISPR-Cas9 approach. And then the other is to edit the beta globin gene locus itself, again using CRISPR-Cas9 to correct the gene defect. So you can see that on the right-hand side of the slide in the figure, you can see that you can correct the gene. That requires homologous recombination, whereas if you want to make the gene non-functional, it can be done using non-homologous end joining as well. The delivery of the edited gene, again, would be by stem cell mobilization, correction, and then myeloablation and delivery again. But there is enough interest now, and there's a lot of work being done to not only, so non-viral viral delivery is important because of reduction in insertional mutagenesis, which again we don't think is going to be a major risk, as well as to prevent the risk of off-target editing that might occur as well. And then obviously the goal would be to try and find ways in which we can do this gene editing without doing the stem cell collection and gene editing ex vivo, but rather to be able to do it in vivo itself. So phase 1-2 clinical trials are underway, and I will give you some of the results of that. So first, the Thales trial of ST400. This was as of December of last year, this was presented at ASH. 3 transfusion-dependent patients were enrolled, with a total of 6 being planned. The process was going to be similar: harvesting, correction, and reinfusion. The results from 2 subjects were available because they had been treated. So subject 1 actually had some kind of a hypersensitivity reaction. The thought was maybe to the preservative in the stem cells, which is DMSO. They were transfusion-free for only about 6. This patient was only transfusion-free for about 6 weeks. But still is on transfusions, but does have elevated fetal hemoglobin levels. So maybe there was some effect of the gene editing. Subject 2 did engraft and had rising fetal hemoglobin levels, but was still on regular transfusions at 90 days post infusion, and we don't really have updates so far. And then subject 3 had only been harvested and had not been reinfused at the time of that presentation in December of 2020. COVID-19. Hot off the press is preliminary results from the CRISPR trial of CTX001 in thalassemia. 2 patients have been treated so far. Both had non-beta 0, beta 0 genotypes. And you can see here that patient 1 is 15 months out, and you can see he's transfusion independent with a total hemoglobin of 14.2, of which 13.5 grams is fetal hemoglobin. Patient 2 is about 5 months out and has a total hemoglobin of 12.5, of which 12.2 is fetal hemoglobin. So what you're seeing is a very efficient editing process, and you can see that if you looked at the peripheral F cells, a percentage of red cells expressing fetal hemoglobin, it's about 100% at 15 months in patient 1 and 99.4% in patient 2 at month 5. So patient 1 is now transfusion independent, 14.2 months with a hemoglobin level of 14.2, and patient 2 is transfusion independent 3.5 months with a hemoglobin level of 12.5. So far successful. In terms of adverse events, 1 patient did have veno-occlusive disease, which was successfully treated. But other than that, the complications are all related to transplant procedures as well. So this is exciting data that has been presented. It's still very early, and it's still only 2 patients, and so we have a ways to go before we can can draw broader conclusions. But this is a great start. So in summary, for gene therapy, beta globin gene addition trials have achieved transfusion independence in patients with beta thalassemia, especially in those with non-beta 0, beta 0 genotypes. Adverse events are typical of myeloablative conditioning. It's well tolerated both in pediatric as well as adult patients. We do still need to have more longer-term data. And there remain some patients who have not had an optimal response, and we have to figure out why that is in those individual patients, and that is being looked at right now. Gene editing targeting BCL11A has been successful in 1 trial out of the 2 at least. However, this will be a very expensive treatment, and the availability to patients will have to be addressed in terms of worldwide, whether it's available to individuals in developing countries as well, and how this will be possible in resource poor areas of the world as well. Finally, I will just mention briefly targeting the hepcidin pathway in beta thalassemia has also been done in clinical trials. So we know that ineffective erythropoiesis results in low levels of hepcidin. This leads to increased iron absorption and iron redistribution to different organs. The thought was that if you gave a hepcidin mimetic, you might be able to improve ineffective erythropoiesis as well as reduce iron absorption and reduce iron redistribution, and therefore prevent it from going to organs where it can cause toxicity, such as the endocrine organs and the heart. So 2 trials were started. One was a trial of LPJ401 conducted by a company called La Jolla. The goal was to see if you could reduce iron in the heart. That trial was terminated early because of futility, and we did not see a reduction in myocardial iron on MRI. The second trial is ongoing. That is the Transcend trial of PTG300, which is made by a company called Protagonist, for non-transfusion dependent thalassemia or transfusion dependent thalassemia, to look and see what effect it has on, again, hemoglobin levels in the NTD patients, as well as transfusion requirements in the NTD patients. And we're expecting to get more data from them as well. And then TMPRSS6, which is another potential target in the hepcidin pathway, has also been considered for use in a clinical trial, but we don't have any clinical data yet. It did ameliorate iron overload and ineffective erythropoiesis in the mouse model of beta thalassemia, but has not been, at least we don't have any data on human use as of yet. So those are all the different targets that have been looked at, affecting erythropoiesis, affecting iron metabolism, and so we're at the point now where we have exciting data from both luspatercept, which is now approved for use, as well as for gene therapy, which is in advanced stages of clinical trials and hopefully will be approved for use soon. So I'm going to stop there and leave time for some questions. What I want to do is to definitely thank the organizers, the sponsors and the organizers, the Cooley's Anemia Foundation, as well as the Centers for Disease Control for hosting this and putting it together, because I think this is a very valuable way in which information can be disseminated to the worldwide community. So thank you, and I'll take questions.
Great. Thank you, Dr. Sheth, for really a great talk. You covered quite a bit, which is wonderful. We're now going to shift to the question and answer section of the webinar. I just want to remind everybody that to submit, to ask a question, just submit a written question using the questions area of your toolbox. I see that many have already come through, and we will try to get to as many of the questions as possible. So I think there are a number of questions, Dr. Sheth, on luspatercept, so I think I will start with those and try to group them together. So the first is something that's actually puzzled me as well, and that is that the person understands that binding to TGF-beta ligands and inhibiting SMAD signaling, that understands the mechanism of action, but how is it that that can possibly work when you still haven't fixed the beta globin mutation?
So that's an excellent question, and I don't know that there is a very exact answer to that. The hope is that you are reducing the imbalance. So it would make more sense in somebody who has a beta plus mutation, obviously, because you're making some beta globin, and if you're able to optimize that binding of beta to alpha, not have as much apoptosis, and the cell comes out, you might have some production of red blood cells that you were not having before. There's also the thought that maybe there is a little bit of an increase in fetal hemoglobin. So the preliminary data showed that maybe there was some increase in fetal hemoglobin, which is not going to be a direct effect of the drug on fetal hemoglobin expression, but more so, I think, on survival of the red blood cells as they're maturing in the bone marrow and are able to then actually come out. So I think it's probably a combination of improved survival of the cells and optimization of the cells that have a better ratio of alpha to non-alpha that are then able to come out and then survive better as well. In the beta 0 patients, we really don't have a good sense, and maybe it's just a survival benefit, but we are seeing, and the clinical trial, even though I didn't show the subset analysis, but even the beta 0 patients did have a response. It was not statistically significant, but there was a significant trend towards statistical significance, even in the beta 0 patients. So don't have good answers. I think what we are going to really need to look at is what is exactly happening in the bone marrow, and what are these cells that are actually coming out. So I think that is something that will be studied, and we will have better knowledge of that in the future.
Great, thank you. And then along the same lines, any information on using this drug in alpha thalassemia?
No, we don't have. So the trials have not included alpha thalassemia at all. Interestingly, other agents that have been developed. So, for instance, I didn't talk about this in detail, and they did present some data at EHA. The pyruvate kinase activators, those are being used in alpha thalassemia as well as beta thalassemia. So the study that was presented was a small study of 13 patients, I believe, that received the PK activator that Agios is the company that makes it, and the drug is called mitapivat. And they showed that there was an increase in hemoglobin in the non-transfusion dependent beta thalassemia patients, about 1.5 grams, and in the alpha thalassemia patients, so these are mostly hemoglobin H patients, had an increase in hemoglobin about 1.2 grams as well. So we don't know about luspatercept specifically because that has not been used in alpha thalassemia, but some of the newer agents are being looked at in alpha thalassemia as well.
Great. And then there's questions on, is there any information on use in the pediatric population and any idea of when it might be approved for use in children?
So the clinical trial is ongoing as we speak. The company has not released information as to when they will complete the trial, but the hope is that in the next year to year and a half, they will have data. The pediatric trial is not a huge trial, so that data hopefully they will have soon, and then the larger trial that they're conducting in the non-transfusion dependent patients will probably take longer, and that probably is going to be maybe a year and a half to 2 years before we have that data available as well. But the pediatric trial is underway, and hopefully they will be able to add that to the indications in the next year.
Great. And then there's questions about the use of luspatercept in non-transfusion dependent beta thalassemia, whether you think that genotype might actually be better suited to the drug than even transfusion dependent patients.
So yes, I do think that population is going to benefit quite a bit from this drug. Again, just as we discussed in terms of the sort of basic mechanism of action in the bone marrow, again, if you're making beta globin chains themselves, then yes, you're going to be able to optimize that. And so the patients who are making beta globin chains, which are the beta plus patients who are the thalassemia intermediate non-transfusion dependent patients, I think will show a tremendous benefit. If the phase 2 data is anything to go by, where they had sustained increases in hemoglobin of 1.5 grams or so, I think that that will be a tremendous benefit to non-transfusion dependent patients especially with lower hemoglobin levels, to be able to boost their hemoglobin levels, reduce the ineffective erythropoiesis, and maybe reduce things like bone disease and extramedullary hematopoiesis as well in those individuals. So I absolutely think that it will be beneficial. Again, the clinical trial is underway, but theoretically, it makes perfect sense that it would work well.
And then there's a couple questions on how, now that the drug is approved, have the results in clinical practice been similar to what we're seeing in the studies, as well as concern for the effect of luspatercept wearing off over time, patients who initially had a reduction in transfusion requirement, but then their transfusion requirements seem to go back up.
So what I can say is that it's only been approved 6 months, and we don't really have a whole lot of post-approval data in sort of real-world application yet. But what I can say is that after the BELIEVE trial, patients were able to transition over, including patients who were in placebo during the trial, were able to transition over into their open-label long-term trial. So that is ongoing, and so far, the data has not been published, but we haven't heard anything about the effect wearing off. So this is now patients who are probably 3 and 4 years on the drug since the initiation of the trial, or at least 3 years or so. Again, that has not been published, but we haven't heard anything about patients losing their response. Again, this is relatively short term, right? It's 3 years or so. But if that's any indication that it is durable, then yes, so far it seems to be quite durable.
Okay, and then any information on whether or not luspatercept use can decrease spleen size or decrease extramedullary hematopoiesis?
So the data from the phase 2 study did show that there was some improvement in ineffective erythropoiesis, some improvement in extramedullary hematopoiesis as well. They have not really shared that data. It is still being, so the BELIEVE trial was a huge trial, and all of the data has not been published yet. So some of those subset analyses are being looked at. I think that it will be, you'll have much better you'd have a much better answer in the non-transfusion dependent patients. And I know that spleen volumes are being measured for that trial specifically to see whether or not, the spleen actually it shrinks in size as the ineffective erythropoiesis improves. So don't know for sure, but if the phase 2 trial was anything to go by, then you did see a trend towards that improving as well.
We just have really a couple more minutes, so I'm going to move to a couple of gene therapy questions. The first is what are appropriate ages for gene therapy? Is there an upper limit and a lower limit? And is there any concern about older patients, such as patients older than age 40, having a worse outcome?
So I think for that, you need to go back and look at sort of transplant data in general. And you have a lot of data available in the allogeneic transplant world where the performance score or the existence of pre-existing morbidities does impact outcomes, right? So older patients who are undergoing transplant have less robust performance scores, who have other pre-existing morbidities, did tend to have more complications and did not do as well in transplant. So I think that the older you are and the more prevalent the more pre-existing morbidities you have, the greater the chances that you might have a complication. So I think that that's something that will have to be balanced. I don't think age alone should be something that sort of either puts you in or puts you out of the transplant mode. I think it should be age that is taken into context along with what else is happening. If you already have cardiac disease, if you already have had vascular disease occurring like pulmonary hypertension, or you have significant renal disease, then you're probably going to have more of those complications that I mentioned related to the transplant itself, and so you might not do as well. Younger kids, and this has been shown from sort of registry data, that the younger you are when you go to transplant, particularly if you're under the age of 12 or 13, you tend to do much better than if you were older. So yes, I think and the rationale for that is I think in thalassemia at least is quite clear. You have a lower risk of having complications related to the iron overload and alloantibodies and stuff like that the younger you are. So I don't think that you should be disqualified if you were too old but you were in really good shape. And I think that younger patients should be included as well, because I think that we know from the allo transplant data that they do very well.
And then there's a few questions for gene therapy. Is myeloablative conditioning needed, and if so, what are some of the long-term side effects associated with that?
So far, it seems like all of the trials have included a myeloablative regimen. If you keep in mind that the marrows of these individuals are quite active pre-transplant, and so if you have residual marrow activity that is ineffective, then that might actually affect the outcome of the transplant itself, and who knows what kind of a balance you might have towards the end. So it's something that has been thought about a lot, but we have not actually moved forward to doing non-myeloablative or reduced intensity conditioning regimens as of yet. I think that this will be something that will be done in the future, but for now, I think the myeloablative conditioning is going to be the way to go.
And then I think there have been a number of questions about when do you think gene therapy will actually be available clinically?
So I didn't answer the second part of the previous question, which was sort of what are the complications or what are the long-term side effects that you worry about? And you do worry about things like developing a secondary malignancy because you were exposed to chemotherapy. It's a very low number, less than 2%, and you worry about things like clonal disease developing as well. Again, a very low number there as well. Again, this is autologous, so you're not so worried about things like graft versus host disease and chronic GVHD and things like that. So complications are not going to be that different from standard transplant, except the sort of more acute complications will be far less because it's an auto transplant compared to an allo transplant. And then in terms of, when it might be approved, I don't know. So through the grapevine, and this is not reliable information, I don't know if it is or not. The first company to submit to the FDA, at least in this country, will be, so gene therapy using the BB305 vector is approved for adults with non-beta 0 thalassemia in Europe. I hear that the same company is going to apply for beta 0 and non-beta 0 and adults and children over the age of 12, I believe, when they submit to the FDA in this country. And I think that it will probably be by the end of this year or early next year that they will submit. And then I don't know how long the FDA will take to decide whether to approve it or not.
Yeah, I agree. I think we're hopeful that it will be sometime soon, but we really don't know. And just to add one last thing to your the long-term effects, I may have missed, but infertility is the one other thing I think we always like to discuss. There is a risk with the myeloablative busulfan dosing of infertility, and so it's important to discuss fertility preservation options with patients and families.
Yes,
okay.
Thanks for that. Yes.
Oh, sure. We unfortunately are now at the end of our hour, and so there were a few questions that we were not able to get to, although I think we got many of the general themes answered. So we're going to have to stop the question and answer period at this point. So I just would like to make a few concluding remarks. First of all, thank you again, Dr. Sheth, for such valuable information on the latest in thalassemia treatment. I would also like to thank each of you for joining us in this webinar. We thank our colleagues at CDC's Division of Blood Disorders for this invitation to be with you today, and the Cooley's Anemia Foundation for hosting this webinar. Very shortly, you'll receive an email asking for